Dear audience, Assalamu alaikum. I am Professor Shamsud, Professor of Pathology. I am going to discuss about hemolytic anemia today. Now come to hemolytic anemia. Respected audience, the last class I have told you about anemia and iron deficiency anemia. Today, hemolytic anemia. Now come to first definition of hemolytic anemia. Anemia results from premature destruction of red cells or red blood cells is known as hemolytic anemia. So, such type of anemia, that is hemolytic anemia, results from premature massive destruction of red cells. Dear audience, you know, this is RBC. This is RBC containing hemoglobin within it. And you know, average lifespan of RBC is 120 days. 120 days. By definition, if the lifespan of RBC is shortened, if the lifespan is shortened, with shortening of lifespan of RBC, if there is massive destruction of red cell, then it is called hemolytic anemia. You know, after 120 days, RBC undergo destruction automatically. If there is massive destruction due to shortening of lifespan of RBC, then there is hemolytic anemia. Now come to classification of hemolytic anemia. How to classify hemolytic anemia? It can be classified as hemolytic anemia due to intracorpuscular defect. Intracorpuscular defect. That is, if the RBC, if any defect within the RBC itself, then there is hemolytic anemia. And this is called hemolytic anemia due to intracorpuscular defect. It is intrinsic mechanism. And another is hemolytic anemia. Hemolytic anemia due to extracorpuscular defect. What it means, the RBC is without any defect, no defect within the RBC, but any defect outside the or surrounding the RBC that may lead to massive hemolysis. Then it is called hemolytic anemia due to extracorpuscular defect, and it is extrinsic mechanism. Now come to hemolytic anemia due to intracorpuscular defect. Due to intracorpuscular defect. Now come to intracorpuscular defect, that is defect within the RBC itself. First one, the defect may be within the membrane. Defect in membrane of RBC that may lead to hemolytic anemia. There are so many defects in the RBC membrane that is associated with premature massive destruction, like spherocytosis. Dear audience, you know, RBC, normal RBC is biconcave disc. If the RBC becomes sphere-like due to deficiency of spectrin one of the cytoskeleton of the RBC, the RBC become sphere, like a sphere. This is the membrane defect. Another is elliptocytosis. Elliptocytosis, RBC becomes elliptical, and stomatocytosis. So these are the defects in membrane associated with the hemolytic anemia. Another is defect in hemoglobin. Defect in hemoglobin. The defect may be two types. One is qualitative defect, or one is quantitative defect. Quantitative defect. Another is qualitative defect. One is qualitative defect. The quantitative defect, you know, is called thalassemia, and the qualitative defect is the structural defect of hemoglobin. It is called hemoglobinopathies. Now come to defect or deficiency of enzymes within the RBC. Deficiency of enzymes in RBC. You know, if any deficiency of glucose 6-phosphate dehydrogenase within the RBC undergo hemolysis. So deficiency of glucose 6-phosphate dehydrogenase. And also pyruvate kinase deficiency. Pyruvate kinase deficiency. So this is the intracorpuscular defect. All these three is known as congenital defect. So all these three defects in membrane, defects in hemoglobin, deficiency in enzyme, these are congenital defect associated with intracorpuscular defect of hemolytic anemia. Now come to, it is congenital. Now come to acquired. Acquired hemolytic anemia, that is associated with the intracorpuscular defect of hemolytic anemia. Acquired may be PNH, paroxysmal nocturnal hemoglobinuria. It is called paroxysmal nocturnal hemoglobinuria. What it happens here? It is chronic hemolysis, chronic form of hemolysis. PNH, paroxysmal nocturnal hemoglobinuria. It is a form of chronic hemolysis. Another characteristics of it, here there is intermittent hemoglobinuria, usually at night. Intermittent hemoglobinuria usually at night. So it is called paroxysmal nocturnal hemoglobinuria. Dear audience, now come to what happens in PNH. What happens in PNH? Dear audience, you know, we have complement system in our body. We have got complement system in our body, and this complement is regulated by a protein. It is called complement regulatory protein. In PNH, what happens? There is deficiency of this complement regulatory protein. So if there is deficiency of complement regulatory protein, what will happen? The complement is not regulated, so there is activation of complement system by alternate pathway. Activation of complement system by alternate pathway, and ultimately there is production of membrane attack complex, and due to production of membrane attack complex, the RBC is affected and RBC undergo hemolysis. So there is intermittent hemoglobinuria in PNH. So this is all about the intracorpuscular defect of hemolytic anemia. Now come to extracorpuscular defect of hemolytic anemia. So here the defect not within the RBC, rather the defects in the surroundings. It will be classified as broadly two types. One is immune mechanism causing hemolytic anemia. One is immune mechanism causing hemolytic anemia. That is, immune system is involved in this situation for massive destruction of red cells prematurely. Examples of it, one is autoimmune hemolytic anemia. Autoimmune hemolytic anemia. In this situation, antibody is formed against the membrane protein of RBC. Automatically, this is called autoantibody, and this antibody reacts with this membrane and causes hemolysis. This is nothing but autoimmune hemolytic anemia. Another is hemolytic anemia in newborn. Hemolytic anemia in newborn. You know, one is erythroblastosis pitalis, that is RH incompatibility. RH incompatibility. Another is mismatched blood transfusion. Mismatched blood transfusion. Mismatched blood transfusion. Besides this, there is another type of immune mechanism causing hemolytic anemia, drug-induced hemolytic anemia. Drug-induced hemolytic anemia. So these are the immune mechanism causing hemolytic anemia. Now come to non-immune mechanism causing hemolytic anemia. Non-immune mechanism causing hemolytic anemia. What are those? One is cardiac hemolytic anemia. Cardiac hemolytic anemia. As hemolytic anemia may be seen in mitral stenosis, as in mitral stenosis. Mitral stenosis. Then microangiopathic hemolytic anemia. What it means? If this is the micro blood vessel, if there is inflammation of this blood vessel, this is called angiitis. So any pathology within this small blood vessel, it is called microangiopathy. If there is microangiopathy, the vessel lumen become narrow, and through this narrow lumen, if RBC wants to flow, it is traumatized, and due to trauma within the RBC, in microangiopathy, RBC undergo hemolysis. Then hemolytic anemia in burn, hemolytic anemia in malaria. So these are the non-immune mechanism causing hemolytic anemia briefly. So this is all about the classification of hemolytic anemia. In short, today I want to discuss about thalassemia. Now come to thalassemia. Dear audience, in the last class I have told you what are the differential diagnoses of iron deficiency anemia. I have told you iron deficiency anemia causes microcytic hypoglycemic anemia, thalassemia also causes that, sideroblastic anemia also causes that, and also anemia in chronic diseases. So thalassemia, sideroblastic anemia, and anemia in different chronic diseases are the differential diagnosis of iron deficiency anemia. Now come to thalassemia. I've told you thalassemia is the hemoglobin defect that causes hemolytic anemia, and it is the quantity defect of hemoglobin. It is quantity defect of hemoglobin. It is not a structural defect of hemoglobin, and it is nothing but a genetic disease. It is genetic disease. Now come to how to define thalassemia. Genetic group of disorder or disease characterized by reduction of rate of synthesis. So it is a genetic group of disorder characterized by reduction of rate of synthesis of one or more normal hemoglobin polypeptide chain. Polypeptide chain is called thalassemia. So it is a genetic group of disorder and it is characterized by reduction of rate of synthesis of one or more normal hemoglobin polypeptide chain. I have told you it is quantitative defect. As there is reduction of rate of synthesis, so there is defect in quantity, not in quality, not in structural defect. So we have to recapitulate the normal hemoglobins in our body. Normal hemoglobins in our body. One is adult hemoglobin. Adult hemoglobin. You know, adult hemoglobin may be hemoglobin A, or it is A1 also, and hemoglobin A2. And hemoglobin A1 or A, the polypeptide chains are alpha 2 and beta 2, and A2 alpha 2 and delta 2. And it is about 97%. It is about 2 to 3% in our body. And another normal hemoglobin is fetal hemoglobin, and it is alpha 2 and gamma 2. It is less than 1%. So this is the normal hemoglobin present in our body. By definition, reduction of rate of synthesis of one or more normal hemoglobin polypeptide chains. So it is a polypeptide chain, alpha polypeptide chain, beta polypeptide chain, alpha polypeptide chain, delta polypeptide chain, alpha polypeptide chain, and gamma polypeptide chain. Ultimately, we have got alpha polypeptide chain, delta polypeptide chain, beta polypeptide chain, and gamma polypeptide chain. 4 polypeptide chain within the all hemoglobins. So by definition, if reduction of one or more normal hemoglobin polypeptide chains, then it is called thalassemia. Now come to how can we classify thalassemia. Now come to classification of thalassemia. Briefly, we can classify thalassemia as alpha thalassemia, where reduction of rate of synthesis of alpha chain only, and beta thalassemia, where by definition reduction of rate of synthesis of beta chain. This is called classification of thalassemia in brief. Today come to beta thalassemia. Today come to beta thalassemia. Before that, we have to recapitulate one. Before that, we have to recapitulate one. If alpha chain synthesis is reduced, if alpha chain synthesis is reduced, what happens? Dear audience, if alpha chain synthesis is reduced, what happens? You know, the alpha chain reduction may be sufficient reduction, may not be sufficient reduction. If alpha chain synthesis reduction is not sufficient, it means there is reduction of synthesis of alpha chain, but the reduction is not sufficient. What will happen? There will be reduction of A1, alpha reduced, it is reduced. 97% is reduced. Alpha reduced, so A2 is reduced, 2 to 3% is also reduced. Alpha reduced, so less than 1% is also reduced. What will happen? If there is reduction of alpha chain synthesis not sufficiently, then all the three hemoglobins, A1, A2 and fetal, all will be reduced. As all will be reduced, RBC become microcytic hypochromic. So here A1, A2 and fetal hemoglobin all reduced. All reduced and RBC becomes microcytic and hypochromic. Dear friends, again, if alpha chain reduction is not sufficiently reduced, what will happen? All the three hemoglobin will be reduced and ultimately RBC become microcytic and hypochromic. Now come to if alpha chain synthesis is sufficient. If alpha chain synthesis reduction is sufficient, if alpha chain reduction synthesis reduction is sufficient, what will happen there? Alpha is sufficiently reduced, alpha is sufficiently reduced, alpha is sufficiently reduced. In that case, the beta chain in case of 97% will not get any alpha if alpha is sufficiently reduced to produce hemoglobin A1, and gamma chain will not get sufficient alpha to produce fetal hemoglobin. In that case, what will happen? As there is sufficient reduction in the synthesis of alpha chain, the beta chain will not get alpha sufficiently, so beta chain will be aggregated. So beta chain will be aggregated, and this aggregated beta chain is called aggregated beta chain is called hemoglobin ACE. Hemoglobin ACE, aggregated. And if alpha chain is sufficiently reduced, then gamma will not get alpha and gamma will be aggregated. Then gamma chain will be aggregated, and this aggregated form is called Bart's hemoglobin. Bart's hemoglobin. Bart's hemoglobin. Bart's hemoglobin. Bart's hemoglobin. Both hemoglobin ACE and Bart's hemoglobin, these are the unstable hemoglobin. These are the unstable hemoglobin. If within the RBC this unstable hemoglobin either beta 4 or gamma 4, due to instability of these hemoglobins, the RBC become ruptured or destroyed, and it leads to hemolytic anemia. Again, I can say Bart's hemoglobin and hemoglobin A's. These are the aggregated form of beta chain or aggregated form of gamma chain. These are the unstable hemoglobin. Due to its instability, RBC undergo premature destruction, and that is hemolytic anemia. Again, come to if beta chain, now come to if beta chain synthesis is affected. If beta chain synthesis is affected, if beta chain synthesis is affected, what will happen? If beta chain synthesis is affected, what will happen? First come to if the beta chain synthesis reduction is not sufficiently affected. If reduction of beta chain is not sufficient, then what will happen? If not sufficient, if not sufficiency of reduction of beta chain synthesis, what will happen? A1 will be reduced. A1 will be reduced, and at the same time, A2 and fetal hemoglobin will be increased. What will happen? Here, hemoglobin A1, it is reduced, but hemoglobin A2 and fetal hemoglobin, these will be increased. And if reduction of beta chain sufficiently affected, if beta chain synthesis is sufficient, then what will happen? If sufficient reduction of beta chain, what will happen? The alpha will not get any beta in that case, so alpha will be aggregated. If sufficient reduction of synthesis of beta chain, alpha chain will be free, and it will not get to produce any A1 in combination with beta chain. So the free alpha chain will be aggregated. So there will be aggregation of alpha chains. There will be aggregation of alpha chains. Aggregation of alpha. And this aggregated alpha is unstable hemoglobin and will lead to hemolytic anemia. So this is the. Now come to beta thalassemia. Now come to beta thalassemia. And we can classify beta thalassemia as beta thalassemia minor. Beta thalassemia minor. What it means? It is a trait. Beta thalassemia minor means there is reduction of beta chain synthesis, but the reduction is moderate, not sufficient. Reduction of synthesis is moderate. Reduction of beta chain synthesis is moderate. So there is moderate beta chain synthesis. Another is beta chain or beta thalassemia major. What it means? Here the reduction of beta chain synthesis is sufficient. So sufficient reduction of beta chain synthesis. So sufficient reduction of beta chain synthesis. This beta thalassemia major again classified as 2. It may be 1 beta plus thalassemia. Beta plus thalassemia major. Beta plus thalassemia major. What it means? It means the reduction of beta chain synthesis is sufficient but not almost zero. There is sufficient reduction of synthesis of beta chain, but it is not almost zero. it is called beta thalassemia plus, and another is beta 0 thalassemia. What it means? Here the reduction of beta chain synthesis is sufficient, and the sufficient synthesis means almost zero synthesis or no synthesis at all. If no synthesis of beta chain, it is called beta 0, or if almost nil synthesis, it is called beta 0. But sufficient but not almost nil, it is called beta plus. Again, sufficient but almost nil, not almost nil, it is called beta plus. But sufficient, almost nil, or completely nil, it is called beta 0. Dear audience, now come to beta thalassemia major. Now come to beta thalassemia major or beta thalassemia. Now come to clinical presentations. Clinical presentation of beta thalassemia. Again, recall, thalassemia means reduction of rate of synthesis of one or more normal hemoglobin polypeptide chain. We are talking about beta thalassemia means here the beta chain synthesis rate is reduced. There is reduction of synthesis of rate of beta chain or beta chain of hemoglobin. It is called beta thalassemia. If any baby body suffers from beta thalassemia, what may be the presentations of that body? Presentations. Number 1, symptoms of anemia. As the individuals or the baby suffers from reduction of hemoglobin, so this is by definition anemia. And symptoms of anemia, the pallor of the skin sclera, effort intolerance, palpitation. So these are the different types of symptoms of anemia patient may show. Another is retarded growth. Dear audience, as you know, it is a genetic disease, and this disease, the patient suffers from thalassemia since birth. As the patient suffers from since birth, there is reduction of hemoglobin in the body. There will be tissue hypoxia, cellular hypoxia from since birth. So there will be retarded growth of that baby. Frequent fever. As since birth, the baby is anemic. Due to anemia, the protection of the baby is reduced. Self-protection is reduced. Immunity is reduced. So there will be frequent infection and it will lead to frequent fever. Mongoloid facies. What it means? The faces of that baby become mongoloid. How it occurs? You know, as since birth, the baby is anemic. As since birth anemia, what will happen? Within the blood, due to reduction of hemoglobin, oxygen tension or oxygen amount of oxygen in the blood is reduced. So there is tissue hypoxia, cellular hypoxia. And due to anemia, there is synthesis or production of erythropoietin from kidney, you know, from physiology. And this erythropoietin acts upon the bone marrow. As the erythropoietin due to anemia in thalassemia acts upon bone marrow, the bone marrow undergo hyperplasia. As bone marrow hyperplasia occurs in the malar bones, hyperplasia of bone marrow in malar bones, there will be mongoloid facies. As there is hyperplasia of the bone marrow in the malar bones, the malar bone due to hyperplasia marrow become expansion. Due to expansion of the malar bones, there will be development of mongoloid facies. The patient may suffer from splenomegaly. Dear audience, you know the RBC after 120 days on an average undergo destruction within the spleen, and it is the role of spleen. So if there is premature massive destruction of red cells since birth, and this destruction occurs in the spleen, and their spleen become hyperactive, and ultimately there is splenomegaly. Spleen is increased in size. There may be hepatomegaly also. Hepatomegaly. The patient may come to you with jaundice. You know, as there is hemolysis, there will be hemolytic jaundice. Patient may come to you with cholelithiasis. The baby may develop a stone within the gallbladder. The baby may develop a stone within the gallbladder. This is the pigment stone. This is the bilirubin stone. As since birth the patient suffers from jaundice, there is sustained hyperbilirubinemia in the blood, and due to hyperbilirubinemia blood, the bile is saturated with bilirubin, and there is super saturation of bile with bilirubin, and the bilirubin is precipitated here, leading to formation of bilirubin stone. So the baby develops a stone in the gallbladder, that is cholelithiasis. Sometimes baby may develop pathological fracture of bone. Pathological fracture of bone. You know, pathological fracture of bone means the fracture of bone due to tiny injury, and it is due to pathology within the bone. As there is, suppose this is the bone medullary cavity, and this is the bone. And this one is medullary cavity. If there is hyperplasia of bone marrow, what will happen? There will be thinning of the cortex. As the thinning of the cortex, there will be trauma, mini trauma may cause bone fracture, and this is called pathological fracture in thalassemia. So these are the important clinical presentation of thalassemia briefly. Now come to, if the baby suffers from thalassemia, how can we diagnose thalassemia in laboratory? Now come to laboratory diagnosis of thalassemia. We have to do first blood examination, biochemical test, then bone marrow examination, and lastly hemoglobin electrophoresis. So these are tools. Diagnosis of thalassemia in laboratory. First come to blood examination. We have to do first hemoglobin. Hemoglobin percentage, it will be reduced. As thalassemia is nothing but anemia, so it will be reduction of hemoglobin first. Then ESR, it will be elevated. As there is frequent infection causing frequent fever, due to frequent infection, there is chance of elevation of ESR. Then total leukocyte count, it may be normal or sometimes leukocytosis. If there is concomitant infection in case of thalassemic patient, there will be leukocytosis. If there is no concomitant infection, the TLC will be normal. Then differential count. It is normal, or sometimes it may go predominance of neutrophil. When there is infection, there will be predominance of neutrophil. Then peripheral blood film, PBF, peripheral blood film. It is important for diagnosis of thalassemia. What can we get in peripheral blood film in thalassemia? Dear audience, you know, in peripheral blood film, we see all about the RBCs, we see the WBC series, and we see the platelet within the blood film. Now come to first RBC series in peripheral blood film in thalassemia. What you'll get in RBC series, you'll get microcytic, hypochromic, RBC with anisopoikilocytosis. So it is morphologically, it is microcytic hypochromic anemia, you know. So RBC will be microcytic or hypochromic. There is RBC reduced in size, and there is reduction in hemoglobin within the RBC, and there will be anisopoikilocytosis. What it means? There is different shape of RBC. Different shape of RBC you will get in thalassemia. In addition to this, what will be the additional findings in thalassemia? In addition to this, there will be cystocytes. Cystocytes means fragmented RBC. As it is hemolytic anemia, you can get hemolyzed or fragmented RBC, and it is called cystocytes. Cystocytes, teardrop cells, target cells, and nucleated red cell. Dear audience, cystocytes is the fragmented RBC found in hemolytic anemia. Teardrop cells like the cells like the drop of teardrop cells. You can get target cells. Target cells is nothing but this. You know, in normal RBC there is central one that is paler, but in the target cell the central part is not paler. There is hemoglobin, and around the central part there is again the peripheral part hemoglobin, and in between two parts there is less hemoglobin area, and this is nothing but the target cells. And you will get RBC with nucleus, and this is called nucleated RBC. You know, normal mature RBC does not have any nucleated red cell, but in case of thalassemia you will get nucleated red cell. Why nucleated cell is found in thalassemia? As in thalassemia there is premature massive destruction of red cell, as the patient is anemic. For rapid production of RBC from the bone marrow, due to rapid production of RBC to compensate the anemia, due to rapid production of RBC in the bone marrow, sometimes immature RBC with nucleus comes out from the bone marrow in the blood, that we get in the peripheral blood as nucleated red cell. Then WBC series, WBC mature with normal count and distribution. So WBC within the peripheral blood shows normal maturation, normal count, and normal distribution. It means it is not a disease of WBC, rather it is a disease of RBC. In the peripheral blood film, again, platelet adequate in number. So normal WBC, adequate platelet indicates it is not a disease of WBC or platelet, but these findings within the RBC, it indicates it is a disease of RBC, that is, it is a case of thalassemia. Dear audience, cystocytes, teardrop cells, target cells, and nucleated cells, these are called evidences of hemolysis in peripheral blood film in thalassemia. These are called evidences of hemolysis. What are those? Cystocytes, teardrop cells, target cells, and nucleated cells. These are called evidences of hemolysis in thalassemia in peripheral blood film. Now come to biochemical test. What biochemical test we do to diagnose thalassemia? Number one, serum bilirubin. Dear audience, you know it is nothing but hemolytic jaundice. So there will be elevation of serum bilirubin. It is elevated. You know, normal bilirubin is up to 1 milligram per deciliter of blood. So it will be raised. Number 2, serum fetal hemoglobin. I have shown you a few minutes ago. In case of beta thalassemia, fetal hemoglobin is raised. So there will be elevated fetal hemoglobin. Dear audience, you know normal fetal hemoglobin in our body, in my body also, less than 1%. And this fetal hemoglobin will be elevated in thalassemia. You know, fetal hemoglobin is normal hemoglobin. If normal hemoglobin is raised in thalassemia, why it is injurious? As it is normal hemoglobin, and this normal hemoglobin will be elevated in beta thalassemia. Why this elevated normal hemoglobin is injurious for the body? It is injurious is due to, you know, fetal hemoglobin has got more affinity for oxygen. And if you see the oxyhemoglobin dissociation curve, the baby having more and more fetal hemoglobin, the oxyhemoglobin dissociation curve which is shifted to left. What it means? It means the baby containing or having more fetal hemoglobin, the fetal hemoglobin has more affinity for oxygen. The fetal hemoglobin does not releases oxygen in the tissue sufficiently. So although there is increased amount of normal fetal hemoglobin body, there will be tissue hypoxia or cellular hypoxia because of more affinity of fetal hemoglobin for oxygen. So the tissue and cellular level become hypoxic. Another one, serum uric acid. It will be elevated because there is turnover of cell, there is premassive massive destruction of red cell. It leads to increased uric acid level in the blood. Then serum iron, it will be elevated. As there is hemolysis, from the hemoglobin iron is released, and this released iron causes increased serum iron. Then ferritin saturation. The ferritin saturation is completed in the body. It is completed. As iron is released from the destroyed RBC, so there is completion of ferritin saturation in plasma. Then serum haptoglobin, it will be decreased. Dear audience, you know haptoglobin is a glycoprotein, and this glycoprotein is synthesized from the liver. This glycoprotein is synthesized from the liver. It synthesizes haptoglobin, synthesized from the liver. And this haptoglobin, you know, normally in our body after 120 days on an average, RBC undergo destruction normally, and from the destroyed or ruptured RBC after 120 days, hemoglobin is released. And this normal hemoglobin that is coming from the normal hemolysis of RBC after 20 days is taken by this haptoglobin. The haptoglobin takes or binds with the normal hemoglobin, and there is no hemoglobinuria. As the haptoglobin synthesized from the liver binds the normal hemoglobin, no hemoglobin is to be excreted in urine. But if there is hemolysis, more and more hemoglobin, and haptoglobin binds with the hemoglobin, and ultimately there will be no haptoglobin to bind the other hemoglobin. As there is no haptoglobin to bind the other hemoglobin, there will be serum haptoglobin will be decreased. Now come to bone marrow examination. Dear audience, as there is anemia since birth, bone marrow tries to compensate the anemia, so bone marrow undergo hyperplasia. So bone marrow examination shows marrow hyperplasia only. Marrow hyperplasia. So marrow hyperplasia is the findings of bone marrow examination. And lastly, hemoglobin electrophoresis. If it is a case of beta thalassemia, again we can recapitulate alpha 2, beta 2, A1, alpha 2, delta 2, A2, and alpha 2, gamma 2, fetal hemoglobin. If there is sufficient reduction of beta chain, it will be aggregated and it will lead to hemolysis. So there will be increased A2, and increased fetal hemoglobin. Fetal hemoglobin as there is reduction of beta chain. So what will be electrophoresis findings? It will indicate the increased A2 and increased fetal hemoglobin. Fetal hemoglobin. It is about 10% to 90%. But normally it is less than 1%. So it indicates it is a case of beta thalassemia. So this is all about the laboratory diagnosis of beta thalassemia, and this is the end of today's lecture. Thanks all.